Okay, so let's start. So just a little bit of sort of getting everyone on the same page so that we know all sort of share what we're talking about. And I suppose the first thing is to say, you know, it's blindingly obvious to everybody that the world's a pretty unfair place. And we often talk about equality as being the answer to that. And, you know, EDI, you know, usually has equality at the beginning. The clear problem with equality is, as you can see, is that if you treat everybody in the same way, it doesn't actually do much to really make the world less unfair. So actually the sort of conceptualization of what we might want to keep in our minds is this idea of equity rather than equality. So that actually there are times when we need to do things differently to make up for the fact that actually the place that we work or the things that we do are in the context of the world not being fair and everyone not having the same advantages at the beginnings of their lives or indeed throughout their lives. So we want to make sure that what we do as programs or as individuals address that really stark set of inequalities that people experience. So we're going to talk specifically about health inequalities today because we work in health and care. And health inequalities are often sort of people just talk about this idea that there are differences in health between different groups of people. And that's sort of fine, but it actually isn't substantive enough as a definition. So what we really want to understand is that inequalities are avoidable, they are unfair, and that they're systematic. And it's those things that matter when one wants to think about how one might want to address inequalities. If they're not avoidable, then there's little point in considering whether we should be addressing them. But actually, the reality is that they are avoidable, unfair, and systematic. So as a definition, we need to maintain sort of interest in those three ideas that sit alongside health inequalities. Very often people talk about health inequalities in terms of protected characteristics, so protected in terms of the law. And those are the 9 protected characteristics, which I'm sure everyone's familiar with. And indeed, it is obvious that many of those characteristics can lead to health inequalities. However, the reality about many of the groups that we might want to consider when it comes to thinking about work that we might want to do with specific communities to reduce health inequalities is that set of protected characteristics doesn't go far enough in terms of our understanding. So if we want to think about health inequalities broadly, then put in the chat, what sort of groups of people do we want to consider apart from those with protected characteristics? And Lucy, if you can tell me what people put in. So which groups would we want to consider in our work? Any ideas for anyone there? I can't see. Gosh, you're very quiet. Everybody be
eating. Those in poverty, social deprivation, marginalised populations, low income.
Yes, absolutely. And the reality is that it is, if one's going to think about the sort of work that we might want to do, actually we need to consider a whole range of groups of people who we know can experience health inequalities. And that might be looked after children, refugees, travellers, carers, people who use substances, the homeless, people with poor literacy, either general poor literacy or specific health literacy. Issues of geography, so rurality is one. People who have got a history of offending. And we know all of those groups can experience health inequalities. And the things that sort of underpin quite a lot of that is that they may be marginalised and there may be significant deprivation, discrimination or systematic ways in which the system does not support their health or their care. But the other things that sit beneath it are, of course, wealth, income, and power. And actually, it is that sort of mix of things that make those health inequalities really stark for people. It's not simply belonging to a group. It is that mix of both things that are about yourself, about your genetics, or about your where you were born, that actually work together, so that the health inequalities arise because there are differences in incidence and prevalence of disease between different groups. And that might be, as I say, it might be due to a genetic factor, it might be due to where you live, it might be due to wider determinants of health, so poverty being the thing that underpins an awful lot of these differences. It might be that actually the inequalities arise because there are differences in the way in which you can access services, either because the services are inaccessible to you, or indeed because there are challenges for you in terms of access. So that might be, as I say, around health literacy or around language. It might be that actually the inequalities arise in terms of the outcomes of the care that you get, and those outcomes might be clinical, safety, or experience outcomes. The important thing is that when we want to think about a piece of work that addresses health inequalities, we have to understand the wider determinants of health for that particular condition. We have to understand the epidemiology, and we have to understand whether or not there are systematic differences in access or outcome issues. It's not just enough to say, we know generally that this group tends to experience health inequality. So it's not just an issue because the group has a protected characteristic. Who said this? There is no such thing as single issue struggle because we do not live single issue lives. Anybody know? The clue's in the picture.
Is that Maya Angelou?
No, it isn't. Could be. It's the sort of thing she might have said, I think. So this is Audre Lorde, and she is well, she described herself as a Black lesbian mother, warrior, and poet. And was an American writer. And the reason for sticking the quote up is because we know that you can't just understand things in isolation. You can't just understand the differences in gender without taking into consideration all the other aspects of life that somebody might or a community might experience in order to genuinely understand what impact that has on health conditions. So this idea of intersectionality. And the reality about intersectionality is it is not even as straightforward as understanding people's set of risks, because actually it's only in the understanding of the potential protective factors that people might experience as alongside risk that actually gives us an understanding of what might happen to any individual community at any point in time. So the fact that, you know, my mum is elderly in her late 80s, has significant heart conditions and risk factors for other health inequalities, doesn't mean to say that actually she's necessarily vulnerable or necessarily at risk, because my sister lived next door to her, so her social contacts are good, because she has reasonable health literacy, because she has reasonable access to money. So all the things that actually sit alongside her risk factors are mitigated significantly by the protective factors. And those are the things that are really complex to understand in any particular given piece of work, because it is not enough just to look at risk factors. So what does that mean in terms of how we might work? Advancement of equity ought to be something we want to consider. Understanding of health inequalities ought to underpin the work that we do, so that we have clear, proportionate decisions in relation to implementation plans, metrics, and community involvement activities. And the key thing for me in that is that it is the way in which we sit down and understand health inequalities for each individual piece of work that matters. And that means understanding the epidemiology, looking at what the literature already tells us, not just saying the answer is to go and talk to community X. Talking to community X only makes sense once you have already understood clearly what the health inequalities may or may not be for this particular condition that we're looking at, and that then decisions can be made in conjunction with communities about what sorts of things that means for particular pieces of work, whether or not we need to do a piece of work in this with the Nepalese community in Reading for looking at cardiovascular disease, say. So community involvement. Two things to remember. Involvement is working with patients, carers, and the public to improve things for everybody. So whether it's research, innovation, or education. And all involvement is not co-production. Co-production is underpinned by understanding the power imbalance and involving people from the very beginning. We do not, it's not, going back to this word proportionate, not all involvement is co-production, and not every project needs to be co-produced, but you do need to make a decision about how you do that. Because tokenism is rife, and so what tends to happen is if involvement activities are undervalued to start with. They aren't done very well. If they're not done well, they make little impact, and so they're further devalued. So there's something about, as I say, being explicit at the beginning of projects as to how you're going to approach things. And that means being explicit about understanding that you do not know what someone else's experience is like, and that there are a range of different people that you might want to involve with different skills and experience at any one point in time in a project. And that might be looking for experts by experience, and that might be people who come from a particular community, experience a particular condition, or use a particular service. You might want to ask for representation from a community. That's different from asking from lived experience. You can't ask any one individual to represent the views of everybody, but you might want to go to a patient support group or an charity to do that. You might just simply want somebody who's outside the system, somebody who's not you, somebody who's not employed, who can actually comment and make suggestions for a much broader group of the population as opposed to particular communities. And you might want methodologists. The reason for putting that up there is, if we're going to think about health inequalities in connection with a community involvement plan, actually understanding that there are different sorts of community involvement is a really important part of being able to create a plan that addresses the inequalities that you have recognised in your initial search of the literature. And the reason for doing all of this is to remember that actually we don't, without actually involving the people that are there who are going to receive services or who are the recipient of services, we get things wrong. And I like this particular video because it shows how wrong you can get it. So this would have been me going head first, and you can guarantee that somebody spent a lot of time and money designing this slide without actually really understanding what children wanted to do with it. And as you can see, absolutely nobody actually uses the slide. So it's about being clear that we can't know these things without going to the community and asking. And that was my bit of introduction just about health inequalities and community involvement. We're now going to hand over to Nicky, who's going to talk a little bit about some specific work that they've done in Manchester.
Thank you, Sian. So yeah, just to recap, I'm Nicky Timmis. I'm the Public and Patient Involvement Engagement Manager for Health Innovation Manchester. I was hoping to be joined this morning by one of our very active and committed public contributors, the wonderful Nazreen Akhtar, but unfortunately she's quite poorly, so she's unable to make it. But I'm going to do my best to give, provide an outline of her contribution to this project that will really do it justice. So the project I'm going to focus on was called the Digital Tools in Primary Care. And we delivered this during the pandemic. And the reason why I am focusing on this project is because we really did try to be inclusive and engage with people and communities whose voices are seldom heard, and groups that are marginalised in some way. Now, I can make the report available to you all in case anyone would like to do any further reading or are interested in the findings. But for the purposes of today, I'm going to really focus on what we did and how. So that's the strategies and approaches that we use to try and be more inclusive. I'm also happy to answer any questions at the end if we have time, and also do feel free to contact me. I'll put my email address in the chat later if you'd like to discuss it more. So the Digital Tools in Primary Care projects. Now, we're all aware that that there's been challenges around conducting face-to-face activities, is one consequence of the pandemic. And another one has been an acceleration really in the use of online and digital platforms, just like we're doing now. And this acceleration includes the use of online and digital solutions in primary care, such as GP surgeries. Research indicates that the rise has been as much as 80% during the pandemic. The problem is not all GP surgeries are using the same platforms or offering the same services, nor are the people that they engage with a homogenous group. So the Digital Tools project in Greater Manchester was really launched in response to this. And the purpose was to co-create some universal standards for delivering digital tools, but also to try and create a meaningful way of measuring outcomes to ensure that this new way of working in healthcare didn't exacerbate or create new health inequalities. And there was a range of activity we did for this project to try and be inclusive. We did an online survey, and this enabled us to collect quantitative and qualitative insights from a wide range of local people. And we circulated this survey through, you know, a number of contacts and networks. I think we had something like 449 local people complete the survey. And it was only open for a couple of weeks, so that was quite a good outcome. But we were also keen to gather detailed insights from social groups and communities that, you know, experience the greatest barriers and whose voices are seldom heard or are marginalised in some way. I think we all can probably think of some positives from the pandemic in terms of creating new opportunities to include the public by using virtual methods like we are today. But it's also created many challenges because you can't go out and just do place-based research in the usual way. So for this project, we elicited the support of Health Innovation Manchester Public and Community Panel, and also members of our Greater Manchester Forum. Now, we haven't got time for me to give you lots of information about both of those assets, but if you'd like to learn more about either the forum or the panel, please do visit our website. But by utilising the contacts and relationships and skills and knowledge and expertise of members of our panel and forum, it enabled the Digital Tools project to make really informed decisions about which communities and groups to engage and how we could best approach this. But more than that, by utilising the contacts and relationships of others, it enabled us to include people that would have probably been inaccessible within the time frame, especially in the context of the pandemic. So some of the groups that we were able to include as a result were people over 70, people living with mental health issues and that had learning difficulties, people that were shielding during the pandemic, but also BAME communities we know has been sadly disproportionately affected. Nasreen, who should have been joining me today, was one of our panel and forum members that made this work possible. And in addition to being a member of our panel and forum, Nasreen is also the founding member of Awakening Minds, which is a grassroots specialist Punjabi support service based in Rochdale in Greater Manchester. In the past, I've referred to Naz as a community champion, but Naz has described her role much better herself in referring to herself as a community connector. And I have to agree that that's exactly what she did on this project. I'm quite gutted, to be honest, that we haven't got Nasreen here this morning, as she'd have brought so much more than what I can tell you. It would have, you know, really added something for you to all to be able to hear from her directly. But I'm going to do my best to summarise the value that she brought to this project. So, firstly, Naz helped us build a case really for who we should include in the project. Naz suggested that we should focus on South Asian women. And the reason she said we should do this is because these women often don't stand up for or know their rights. They maybe don't ask for help and just get on with things. Many don't have privacy in their own home, and this can include even when they're accessing healthcare. Many don't have privacy because they may have extended family living in the house. Naz explained there can be a lack of emotional literacy in that often the women don't often know how to put into words what they're going through, which can be a multitude of issues. They can be financially dependent. Some of the ladies that she works with who are over 50 have never even been allowed to go to the doctors on their own. She told us about the cultural attitudes, you know, the belief that, oh, there's nothing wrong with her, she's just attention seeking. and that one lady expressed that her weekly visit to the doctors was the only time she was actually able to leave the house without being accompanied or questioned. NAS was also able to build a case for the project team to engage with BAME community and faith leaders. NAS explained to us that community and faith leaders have their ears to the ground and are very much involved in their local community, so have an awareness of what the current issues are. There's also obviously the issues of digital poverty, language barriers and relationships in trying to engage directly with people from different communities. But NAS also explained that faith leaders have an immense influence on the health behaviour of their communities. As a community resource, faith leaders are really well placed and positioned to organise and foster community participation in health matters. And therefore, we should always, when we're looking to reconfigure health services, should consider collaborating with faith leaders. Another reason for working with Nazarene so closely on this project and something that made her an enabler was that Awakening Minds, the project that she founded, she'd set up a WhatsApp group to enable her to move her face-to-face contact online. This meant that there was a ready-made audience that through Nazarene's efforts had built up a degree of confidence and a means to engage with the project. But that was only possible because of the relationships and trust that Nazarene has. These have been developed over many weeks, over many months, and in some cases over many years, something that I just wouldn't have been able to replicate. Naz also worked closely with me to co-design the discussion groups. Her knowledge, experience and cultural insights really enabled us to understand what might work best and draw up clear plans, which included delivering the sessions in Punjabi. Nazarene advised that we needed to also allow some flexibility in terms of the delivery, which turned out to be just spot on. So we'd set a date and a time for the session, but when she was finalising the plans with some potential participants during one of her Friday evening groups, it became apparent to Naz that the plans we made weren't feasible. So she decided to act quickly and deliver the session independently the following morning. There was a number of reasons for that, but one of them was that she was concerned that some of the participants she'd recruited might just get cold feet if she left it too long. Another point I'd like to make about relationships and delivering the session in Punjabi and also the cultural knowledge that Nazarene had is that not only did she recruit the participants, but by delivering this activity through Nazarene, it really enabled us to make it meaningful. You know, it could be that the participants would feel much more open and honest with Nazarene, and that she was able, you know, to be better placed to understand the semantics and the subtleties of what was being shared. Nazarene was also a co-author on the final report in recognition of the role she played. Now, just to conclude, I'd just like to say that one of the things that we don't tend to touch on when we're talking about inclusion, diversity, inclusion and equality is the impact of doing this type of work on the people that we engage. Nazarene shared with me the experience of some of the South Asian ladies that had got involved in the discussion group. And she said that they were actually overwhelmed that somebody wanted to listen to them and were interested to learn more about their experiences. So thank you all for listening. And if we have time, I'm more than happy to answer any questions that you may have.
Fabulous, Nicky. Thank you so much. I suggest what we do is we move straight on to Kay, and then we should have some time because I think Kay's going to do about 10 minutes. So we should have quarter of an hour, 20 minutes at the end for us to sort of talk to each other a bit. So Kay, over to you.
So, hi everyone, I hope you can hear me. So this for me is, it's more of a story than it is about a program of work. And thanks, Nicky, because everything that you've mentioned really resonates with the involvement and participation of people across our vaccination program. But I'm not going to talk about the vaccination program. I'm going to talk to you about something that was purely incidental, which has resulted as a result of the vaccination program. So for me, it's turned out to be totally transformational, driven by the insights, both qualitative and quantitative, during the vaccine equity, and that's what we call it. So by giving you a background really in what happened. So there were several conversations going on during the Northwest London vaccine rollout, because we realized very early on there was quite substantial vaccine hesitancy. So we knew that. However, as true PPI leads and comms leads, we decided to charge ahead and facilitate lots of great engagement events, you know, inviting people through the normal channels to come and hear all of our fantastic experts that we had lined up to speak to people. You know, DPH directors were there talking about the public health impact. We had all the PCN leaders talk about how it's going to impact on GP practice surgeries during COVID, etc., etc. So we thought we were patting ourselves on the back here and doing a phenomenal job. But actually, it kind of turned out that actually the people that we actually want to attend these events weren't there. And I kind of understood why. And people subsequently said, well, we don't really feel we could have had the open conversations that we wanted to have at those events. So people were actually staging their own events. So that's about the vaccine program. What subsequently happened was there were lots of conversations going on simultaneously across Northwest London about what was happening, and the normal terms of engagement just wasn't cutting it. We weren't getting the right people there to attend. And we found out that the communities were actually staging their own events. They were being facilitated by community champions like Nicky just mentioned, by patient advocate groups like Health Watch, to ensure that they could actually have an open and honest conversation about why there were vaccine hesitancy. So what happened was, I had a conversation with one of the senior program managers who I really see eye to eye with, to see what can we do, because clearly there are broader and wider issues going on across Northwest London. So across every system or organisation, there's always one or two strategic leaders that just get this stuff. You know, it could be a GP or a senior NED, or you're an SDP chair. You tend to wheel these people out every time you want to get buy-in from a senior leader when you're trying to do something slightly off-piste. Well, in Northwest London, we have someone called Bob Claber. He's a consultant pediatrician, but he's also Director of Strategy Research and Innovation at Imperial Hospital, which is called St Mary's. So when we spoke to Bob, we kind of saw eye to eye in terms of we needed to completely change our approach. And our approach was driven by up on high, central government, local government, and it was purely about getting the numbers up. We have to drive the vaccine numbers up. And we came to the conclusion at that meeting that it was completely the wrong approach for Northwest London. That may have worked elsewhere, but it really wasn't working in our boroughs across London. So we started to change the whole approach and change the language from vaccine take-up to vaccine equity. And it was mainly driven by some phenomenal data that my colleagues were producing that demonstrated to all the senior leaders where the hesitant communities were. This is also driving the engagement activity. So we thought, why don't we do something slightly different? Why don't we invite everybody that we know involved in the vaccine hesitancy to evening huddles? And it was only in the evening because everyone was just so busy. There just wasn't another space in the diary. We thought, let's start small. let's see who's going to turn up on Tuesday evenings at 6, just for an hour, to start having conversations about what is going on here. So what I've got here is basically the first objectives that we decided to look at. So it's kind of mainly about reducing the variation and obviously the take up at that time, you know, to do with the vaccine hesitancy. But we wanted the support and we wanted to learn from what was happening across the boroughs, because remember, this wasn't just a health issue. This was the whole of the integrated care system, health, social care, local authorities. Everyone was playing their part in this program of work. How could we possibly get everyone together in the same space to have a conversation about what is going on here? So we decided to set this up, and this was the first aims and objectives. So it was a case of bringing everyone together, looking at the qualitative and the quantitative insights that we had gathered. Lots of information had come from the community engagement events. My colleagues had some fantastic data that they had driven up and was sharing across the piece. So we decided to bring all the key stakeholders together from across our communities, local authorities, NHS, academic partners, so we can identify what these barriers were in terms of that take up and try and co-produce something very different that hadn't been done before, but not to improve the take up, but to improve the equity, to improve the access, which at that time wasn't quite equitable. So we use this kind of rapid implementation and improvement method. So anything that anyone brought to these meetings, we were able to, we're almost given permission to go out and try it and come back and tell us if it had worked. Then we could actually roll it out at scale and share some of this practice. So we use a kind of a collective learning, research and evidence, behavioural insights, expertise to shape how we communicate and engage with our communities and share that learning. So every single Tuesday huddle, we have the purpose of starting with stories. So anyone that attends, you can bring whatever you feel is relevant and a burning issue that you may have where you work, and you haven't been able to have the permission or the capacity or the capability to do what it was that you needed to do. So that story will culminate in identifying a problem or the gaps or barriers that we can jointly discuss and resolve. And everything was co-produced, test and change. So anything we came up with in our smaller groups, we would then almost go back to this kind of PDS cycle, using the breadth of expertise in the room and to co-produce potential solutions that people in that group can action and test, you know, legitimately go away and test it and bring it back and finalize in actions and evaluate what we've learned, evaluate what has worked well. And of course, that will then be driven by the data. So we decided to have 9 of these huddles. I think we're on the 7th or the 8th so far. So this just sets out really some of the issues and some of the topics that have been shared over the last 6 or 7 weeks. So the first and second weeks was purely just about setting the scene. What's the data telling us? What is our community telling us? What's the role in trusting conversations around vaccine? Because clearly what was driven by the system really wasn't working, but what was really working was the community doing it for themselves. And what then tended to happen, we then started to support the community by bringing along the relevant experts who spoke the language, who understand the nuances, who are local to those communities, to start to build that local trust. So from March until April, the types of topics that we've had was just listening to the messages. On the 16th of March, it was absolutely phenomenal. We had Why Now? We had a senior engagement lead from one of our CCGs from, I think, a Nigerian background, really telling systems leaders about the historic racism that the community had faced and why there was the potential vaccine hesitancy. I think everyone was just floored because they hadn't heard this before. They had no idea there was a historical context around vaccine hesitancy. And so Adiola really was an open and honest and really set her soul out, really saying, look, let's be aware of this legacy. Let's be aware and empathize with this. These people aren't vaccine hesitant. They're just really, there's just not the trust there in the system. And the trust doesn't just finish and end, start and end with vaccine hesitancy. That distrust goes across other areas of health and social care services, which is where we get to the health inequalities. So the following week, we had that very conversations about actions, conversations about health inequalities as a group, that we need to work together. We need to understand what this looks and feels like. We need to build up our research, as we've just mentioned, understand it from not just a human perspective, from a research perspective. You know, why have communities been disproportionately impacted by COVID? Let's talk about discrimination, health, self-care. All of these things have had a huge impact. So for me, it kind of opened up this conversation with all these systems leaders who were hearing this stuff, surprisingly, for the first time. So we did then co-production solutions, and then we had a session for young people and children, which was just fantastic, hearing about how they had coped with during COVID and what their potential is to have this vaccine. And I can tell you, if we think we've had problems now getting the vaccine uptake, young people are really resident against this, very much so. So as I said, we had the stories, data and insights. We identified problems, gaps and barriers. We co-produced everything with a wide diversity of people who were attending these events. I think last couple of weeks, we've been up to about 50 or 60 people who attend from a really wide range of people sitting around the table. So for me, as we're talking about health inequalities, this is for the pledge this week. So what can we agree on are the key areas of need in our communities? What are we going to do to help shape our healthcare in a very different way? Now we've got access to all of this great information. Let's not squander it. How are we going to do things differently as a result of having all this great insights? And what changes are we going to commit to working with our communities to address the needs that they've now taken their time to tell us about? So as a result of these huddles, we share each other's contact details because we want to continue the working outside of these groups. So everyone says who they are, what their role is, and leaves their email address and telephone number so that people can contact each other and actually work in collaboration. We then make sure everyone has the blog, videos, photos, stories that they can tweet out to start galvanizing, communities of interest around the issues that we're discussing. And it's just really, really built up a swell of interest, much more people that can actually attend on Tuesday evenings, which we realize doesn't suit everyone. And of course, then we have the feedback sessions. We make sure the write-ups from each session is put on the website so people can have access to that. So lastly, for me, it's just been a phenomenal way of engaging and working across the system. It's the sort of stuff that, patient and public involvement leads kind of dream about, because we've been talking about this for so long. At last, our system in North West London gets it because we're able to get the right people around the table. They now recognise that the system doesn't always have all of the answers. Surprise, surprise. If the issue lies within the community, the solution invariably comes from that community, believe it or not. So 6 weeks of sustained personal insights were gained. Across those wider social determinants, and all our systems leaders now have a really much better, well-informed way of tackling those health inequalities, which is something they've really struggled with for many, many years. And as we know, health inequalities are going up, not coming down. But lastly, just be true. I've been true to myself and my values around this issue. I've really had a lot of barriers to entry in terms of how we can do things differently. But what I say to you, you're not alone. There's always an ally to be found. Go and seek them out and help you to drive these things forward. Thanks for listening.
Okay, thank you so much. I think as a sort of a sort of final reflection, that idea that there are always allies, and that actually it is finding those allies from whichever communities that we want to work with is absolutely key, and allies within our own organisations.